Hey everybody, welcome to the Tim Go podcast. Today I'm joined with a very special guest, former program director at the University of Washington Internal Medicine, Boise, and advisor at Global Talent Medical Docs. I'm here with Dr. Scott Smith. Dr. Smith, welcome to the show. How are you doing today?
I'm doing great. I really want to thank you and Timga for inviting me.
Yeah, of course. I always wanted to speak with you on this issue, man. We're neighbors, and I always want to know what's going on in Idaho, and because we have a lot of folks that reach out to us and to to learn more about the different models in the country. As you know, there's so many models out there, Dr. Smith. So, and everybody's kind of getting confused. Hey, what's going on there? What's going on there?
No, exactly. And it must be so hard for the candidates trying to keep all this straight. I think last time I talked to the programs at WES, I think the nation is up to 22 of these alternative
Wow.
pathways, some of which have actually gone through their state legislatures and others are in the process. But 22
Yeah.
states are trying to do something like this because residency is such a bottleneck for immigrant and refugees.
Yeah, Dr. Smith. Before we dive deep into the program in Idaho, I want to talk a little bit about your journey. You've been an internal medicine physician for a long time. You've been in medical education for a long time. You've been a program director. Tell me a little bit about your background and how did you get into this space of realizing this bottleneck and saying that, hey, I want to be involved in creating a solution for this.
Yeah, thanks, Mohammed. It was a kind of a long, slow process of awakening, I would say. So I was in the residency leadership. I went through that same residency a few years before, and I was in the residency leadership for 23 years, sort of getting used to, okay, MD graduates, maybe DO. I'm starting to figure that out as well, et cetera. So I was going along just trying to understand how do we get our class of interns and what's the best way to do that, et cetera. Um, what happened was my wife is a retired pediatrician, and she was hired by the state to help with this particular little kid who was a type 1 diabetic, young infant, well, maybe I think 1 or 2 years old. So not quite an infant, but really had been going in and out of the hospital all the time because her mother had never essentially gone to school. She didn't even know how to read in her native language, didn't understand numbers. So if you had a set of numbers in one font, like for this reading on your fasting sugar measurement, take
Yeah.
this much insulin, and the fasting sugar machine had a different font. She didn't
Yeah.
know that 13 is the same as 13, basically.
Yeah.
So it was a real struggle. This poor kid was getting bounced into the hospital all the time. And they decided to hire a pediatrician that was retired and a translator to try and solve this problem. Well, the
Wow.
translator turned out to be the first fellow that I worked with. He was from Somalia,
Mhm.
had to learn Arabic to go to Jordan to go to medical school. Then he had to learn English to come to the US to go to residency.
Yeah.
Super bright, as you can imagine, to have just done all this stuff.
Yeah.
And he was struggling because Global Talent as an institution does a real good job with graduates of programs that speak English in many areas. So they're working with teachers, business people, researchers, pharmacists, all of the nurses, all of those things. They were fairly good at tracking them into practice here in the U.S. But the two groups that we found initially, the one was physicians. The rules were way too um, complicated and idiosyncratic. And then the other group later was pilots. We had a
Yeah.
whole bunch of Afghan pilots that, we had no idea how to do this. Well, the pilots now have a Scott equivalent in their group. He was a Marine pilot in Afghanistan, knew all of their commanders, flew with some of them, and is
Wow.
helping them to and they've got one guy that's commercially licensed now, and
Yeah.
everybody's got their their personal pilot license. Well, we were trying to do the same thing for physicians.
Hmm.
So that's kind of how the whole thing started. She just said to this kid, "Hey, you should talk to my husband. He's about to retire and he's going to do this kind of stuff." So he was my
Yeah.
first candidate.
Yeah, wow. What a story, Dr. Smith. And it all comes down to, they always speak about the social determinants of health and, how your surroundings, your education, the language you speak kind of determines like your health outcomes. And we all think like going to the doctor and getting medicine is healthcare these days. But, we forget about those details that, make somebody healthy.
Yeah, and so just to put this all in context for your listeners, Idaho recently, about 4 years ago, became 50th out of 50 in doctors per capita. And we have 97% of the geographic area of Idaho is federally classified as medically underserved.
Wow.
So we have a huge problem. And many years ago, two or three of us program directors got together and lobbied the state legislature and got more money for more trainees. And that following year, we went up to 84% increase in residents and fellows in the state.
Wow.
But we continued to fall behind because people are moving in faster than we can generate new doctors. And
Yeah.
we basically swamped every training person, every training program, every training site. We don't have a lot of room to grow further in that kind of a thing.
Yeah.
So
And
what we decided basically in a nutshell was to create two pathways. We call the pathway one is the usual. Pass your USMLEs, get yourself into a residency and get through that, take the boards, you're all set. Pathway two is to bypass the residency bottleneck because that's a huge bottleneck in almost every state, but certainly in our state. So the legislation that we passed, House Bill 542 in Idaho last year, that was designed to essentially look like a residency, but not require ACGME certification and all of the extra bits that goes with that.
yeah.
And so they will be, to be eligible, they have to have done significant postgraduate training in their home country that approximates residency. If it isn't 3 years long, which many of them don't have full 3 years, then they can use up to 500 hours of clinical time in the U.S. that's in clinical situations. So many
Mm.
of our people are medical assistants. They're working in clinics in various ways and helping and doing small tasks or medium tasks as they're allowed to. And so those kind of things would sort of count to get you started. You had to practice in your home country for 3 years, and you had to have adequate English skills, et cetera, background checks, the usual things. And then you'd be eligible to enter this program, and you would get a
Yeah.
provisional license that's the exact same provisional license our medical graduates get to become residents in our training programs.
Mhm.
It says you can do this under the auspices of this program for X. And in
Yeah.
our case, it's 3 years, just like most of the primary care residencies.
Yeah. And Dr. Smith, how long did it take you to get buy-in from all the stakeholders to get this through the
So
legislature?
this was an interesting process. Muhammad, you gave me some good ideas at the beginning of this because I did two laws. The first one basically wasn't real useful for us, it turned out.
Yeah.
But you told me to get an advisory committee of both the people that are for you and the people that are potentially against you, and
Mhm.
put them all on the advisory committee so you can hear what the arguments are on both sides and prepare yourself as you talk to the legislature.
Yeah.
So that was number one, get a good advisory committee. Number two was my personal senator is a Democrat who very much believes in this. And
Sure.
she's been in the legislature a long time. And so she was just really savvy. And every time I would go up to talk to one of the groups, she would meet with me for a few minutes and say, do it this way. So one of the things, for instance, I was one of the criterion for getting in at that point was following the United Nations High Commission on Refugees recommendations or what's the definitions, right?
Yeah.
And I said, that's the same ones that the US has adopted. And she says, that's great. Don't mention the United Nations. Idaho legislatures hate that. So just say it's the
Wow.
same one as the US. And those kind of little pointers, which I would have stumbled on,
Yeah.
really helped. So that was sort of a weird law. We had 4 residencies that were willing to start this. I had to
Mhm.
get approval from ACGME, ECFMG, and NRMP. And what we were going to do was allow a test case, a pilot study of letting refugees with good backgrounds, full backgrounds, come into internship without having had yet to pass USMLE 1 and 2.
Mhm.
And they would do that during their intern year. Now, that, as you know, is a boatload of work to do
Yeah.
internship while you're passing those 2 tests. But
Yeah.
there were people that were willing to try it and programs that were willing to try and jump on board that. The
Wow.
idea there was there were 2 big barriers. One was the USMLEs and the cost of all that stuff. And now, instead of being a translator or Uber driver, they would get an intern salary. And, built into that would be a little bit of protected time for study and stuff. So it
Wow.
sounded great. The problem was when push came to shove, the law got passed, and then all the sites had to back out because, as I said before, we'd already pushed them pretty hard and they just didn't have any wiggle room. And they're like, when we get this a little better set, then we have more staff. Great, we'll do it, but we can't this year.
Was
So
the
we had,
funding there? Was the funding there? Was the money there?
yeah, the money was going to be there.
Oh wow.
So that was kind of. But what happened with that was I met with in our legislature. I think this is similar to many that the subcommittees on health and welfare are the ones that initially evaluate these kinds of proposals and stuff, and then they send it to the full House or the full Senate.
Yeah.
Well, I went to every single member of the subcommittee on health and welfare for House and Senate. I really read up on the people that I was going to be talking to, And for instance, I would go to the representative who's from Coeur d'Alene up in northern Idaho and from that district, and I'd say, "Oh, I was born in Coeur d'Alene. My grandpa did this, and you probably heard of that. He was part of the CCC camps up in the northern woods, and
Yeah.
just trying to make the connections." Well, that I got unanimous yeses out of that committee
Wow. That's
with a
amazing.
reference to the full House and full Senate, both of which said recommend pass.
Wow.
And then they passed something like 97% to 3 or something. So that blew through pretty good. It taught me a lot and it made those connections. So by last year, when we did this second bill, I already knew those people. We had someone that's a lawyer turned lobbyist that I was working with, really great gal. And we worked together and she was like, "Oh, every time I went to a subcommittee to start talking about this, they said, 'Oh, Smith is behind this? Ah, we know him. Yeah, that sounds good. Go ahead.'" And so we had the same result without all the work ahead of time because they just basically remembered me from the year before.
Yeah. Yeah.
So the long and short of that is put in the time up front. It's well worth it.
Yeah.
Find an ally inside the system
Mhm.
and do what you had me do, which is get all of your supporters and naysayers together so you understand the spectrum of this problem.
Yeah. Yeah. Did the naysayers continue to push back even after the advisory committee was finished? Was there
No,
continued?
no,
No.
we never. So, for instance, there was some concern by the Idaho Medical Association about increasing the competition, et cetera, et cetera.
Yeah.
And when I was able to sit down with them and talk to them about, the numbers of our state
Yeah.
and the fact that these people were trying to select for people that want rural primary care, and you
Yeah.
guys aren't going out there, so this is
Mm.
not like it's competing with you. So
Yeah.
so basically, that was one. The former program director and the head of one of our big residency programs. That's almost it's I think the oldest residency program in the state by 1 year from the one I went through. And he was like, "I don't know about this." And so basically, we got everybody on board through that process of talking to them one-on-one while they were advisors for our committee. And we ended up with essentially no big testimony against us when we went through
Oh,
the Senate and the House. But,
wow.
that's real critical to build those bridges and get the understanding ahead of time.
Yeah, yeah. So, Dr. Smith, you have your policy right now in place. How did you begin to, get everything working when in implementation and getting people hired and into work and all that, and finding the candidates? And maybe the candidates was a little bit easier because of your connections with global talent, but
Well, so
um,
it's been interesting. As you
mm,
know, that these alternative pathways lead to a full unrestricted license in many of them, but
mm,
they don't necessarily lead to you being able to take the primary care boards, either medicine or family medicine.
yeah,
So that's an issue. And if you can't take those boards, there's three things that you're locked out of. The biggest one is hospital privileges in many systems. Won't do
yeah,
it if you're not board certified.
yeah,
The second one is the pay scales from your insurance companies and stuff are kind of locked into full unrestricted practice everywhere, not just in Idaho. And
yeah,
so for some of them, you end up having to bill at a subcategory, kind of like a physician's assistant would. So you're
mm,
bringing in some money, but not as much as you should be for your training and stuff.
yeah,
Yeah, and then the third one, malpractice, often is linked to board certification.
yeah,
So
yeah,
again, you gave me the idea of talking to the American Academy of General Practice.
mm,
That turned out not to work for us.
mm,
When I got to talk to them a bunch. Their CEO really sounded optimistic and that was going to be good. And then I said, "Have you surveyed your folks about those three issues? And did this board under you solve those issues?" And he said, "Well, I don't know." I said, "Well, we need to survey your people and see." And the
yeah,
other thing I said is, "What is the pass rate on your test?" And he said that the pass rate on their test was about 86 or 87%, which I thought that's pretty reasonable. That's kind of like both
yeah,
medicine and family medicine boards, and would probably impress the privileging people at a hospital system.
yeah,
Well, then I got to talk to the CEO, who's a physician,
mm,
and I found out they don't have a test because it's extremely expensive to create your own valid test. So
mm,
what they do is look through all the testing that's been done on the candidate and all of the reference stuff, basically what ECFMG would do too,
mm,
and say, yeah, they seem to be a member in good standing. They've passed what they should pass. And then they give them a certification, but it's not by passing a knowledge test. And the
mm,
second thing is we've tried, I think, 3 times to survey their group, and the return rate is horrible. To just find out, did this allow you to get hospital privileges?
okay.
And so they can't tell me that. And I said, that doesn't help me much then.
Okay, so that's very interesting. So you couldn't find is it because you couldn't find clear evidence that when somebody goes through their process that they would get hospital privileges that kind of made you shy out and
Yeah,
said,
I think the reason was, Mohammed,
"Mm,
because we have a lot of candidates. It's the potential candidates have dried up a lot with the change in administration, as you might imagine. I'm sure that's true in Washington as well.
mm,
But we still have a lot, but almost to a person, they were not willing to go through the pathway to process if they couldn't get hospital privileges.
yeah, yeah,
And
makes
so
sense."
they were all shaking the dice and trying to get into residencies before. And if I fail, then I'll try this other thing. So that
Yeah,
didn't help us. Um, and so what's happened now, just to let you know and keep
mm,
track of this over time, for about 10 or 12 years, I worked really closely with the ACGME and a fellow named Eric Holmbo, who was
mm,
real high in ACGME. He's now head of InThealth, the CEO of InThealth.
okay,
And and Eric and I did a lot of work on competencies and milestones and all of that kind of stuff and how you measure them and how you
yeah,
think about them. So we had a lot in common. I got a hold of him and I said, I've got this problem. It seems to me that these people should be qualified to go on and try and take the board test after this 3-year apprenticeship, which is very similarly crafted to a residency with, we're teaching them milestones and competencies and how to do the supervision in a graduated way, et cetera. And if they don't know it, many of them are already training sites for regular residents.
Yeah.
So Eric was really excited. IntHealth is the ones that have been leading this process where ACGME, IntHealth, and the Federation of State Medical Boards are putting out these advisories about, okay, we have all these alternative pathways. We got to figure something out, right?
Yeah. It's because we've been making noise, right?
Yes, exactly. And they know it. So what I found out was that they are working really closely with the American Board of Internal Medicine, the American Board of Family Medicine. Their leadership is really interested in finding a reasonable pathway forward.
Yeah.
We applied to World Education Services for a grant for implementing these alternative pathways. How do you get it up and going, measure this, do some outcomes, get the people together and stuff. Because we had this pilot program, we are now getting interest, and I'll be meeting again. We met with them yesterday with the IntHealth people, all of them. They're excited about this. They're going to set up a meeting between Eric and the two board presidents for medicine and family medicine.
Yeah.
And say, look, these guys have a pilot. They're doing outcomes that you care about. How about you do one pilot for whatever people make it through their apprenticeship? Let them take your boards and see what happens and follow it closely.
Yeah.
And they are pretty optimistic that those guys will say yes. Because what they've come across is, all right, 22 states are doing this. More are looking at it. It's telling us that the residency pathway is a big barrier to people, that they're finding a way around. We've got to make a fair but, quality way of letting people into the boards and getting past them so they don't have all these barriers to hospital practice and billing and all of that. So we're kind of, today, right after this, I will be interviewing 3 new candidates for our site. We have 1 site signed on. We've got 3 others that are really interested that we're visiting and telling them. Because the first thing that happens, so here's a story that we had he's not young, but he's younger than me. Almost most of the world is younger than me now.
He's still young.
Medical student, internal medicine residency, fellowship in hematology in Spain.
Wow.
Then he went to Salt Lake City and did another fellowship in bone marrow transplant.
Wow.
And then he came to Boise because that's where he wanted to live. Yeah. He went to the big hospital systems oncology group. They offered him a job. And then HR said, no, he can't be licensed in Idaho till he takes a residency. He's not eligible. He has to do an ACGME certified residency. They didn't know about our new bill.
Oh, man.
And so I'm working with that oncology group and that HR group to say, no, there's this other way. Mm-hmm. If he works with that oncology group, spends 3 years, under a preceptor, mm-hmm. which is kind of how that system works anyway. Your first year of practice, you're under a preceptor who just, kind of looks at your charts after you've done stuff and signs off that, this person's not crazy. They're a nice person. The patients seem to like them. They're fine. And so this again, is going to be a pilot for applying this rule. We did have the lobbyist and I addressed, so I did not realize, I guess, that once you get through the lobbying pass, the party's not over yet, not by a long shot.
No, so that's when the party starts.
Rules promulgation and all of this stuff you have to do with the State Board of Medicine. And we went and had a discussion with them about what was in our law and stuff. Yeah. And it's almost identical to the recommended approach that the advisory group is looking at. So that was good. Yeah. They looked at it. They asked us a few questions about, well, what if? And we said, this is how we would propose it. And we would have to be granting an exemption for, let's say someone who's often in the Africa or the Middle East or Central or South America, they did 1 year of mandatory, what I would call like a rotating internship,
Mhm.
paying the country back. Then they usually have done one more year in supervised training. And so they
Mhm.
got 2 years, not three. And it
Yeah.
doesn't look exactly like an ACGME certified residency. And then we
Mhm.
have this clause of, well, if they come and get 500 hours of acceptable clinical experience in the US, those three together should make this. And they're like, yeah, that sounds reasonable. So we ended up not having to change any, to amend anything through rules and promulgation. They were happy with the whole law as it stood.
Yeah.
And we'll
Yeah.
have to go back as we get actual candidates and actual sites. But
Yeah.
we're at a point now where we're just about to move forward, where we're going to try and start with 3 sites and 3 candidates. And of course, we're picking our very super best sites that have
Mhm.
already trained residents or medical students or both, so they're used to this stuff. Our absolute super best candidates that blew the boards away with 250s and 260s and look really good and have had 4 observerships with letters of recommendation, all the things that are so hard to get.
Yeah.
We,
Yeah.
we want like no brainer candidates and no brainer sites to start with and see if we can start with a win-win.
Yeah, and Dr. Smith, I'm just trying to understand like the difference when it comes to billings and when it comes to the economics of it. Because in Washington State, I'm seeing like very good high salaries, even with doctors, because we don't have like a independent or like a full practice scope, full practice pathway. We still folks have to work under supervision, and of the physician, and we're seeing really good salaries, like from I would say 180 to even 250. Like I've been, seeing people getting jobs that way in places. So I think, is it because like Medicaid is maybe like expanded, or like there's more, I don't know, what's the difference? Yeah.
Medicare has not expanded residency slots since 1997, I believe it was.
Yeah. What's the difference though in the alternative pathways? Would you say, why are like insurance billing hard in Idaho? What would you say?
Well, it's hard in some places, not others. It depends on the insurance, like everything else, right?
Okay. Okay.
But it is at the base. What you need is some sort of recompense for the sponsoring institution that allows them to do what we're asking them to do, which is pay them a reasonable salary, give
Hmm.
them malpractice, and give them some basic benefits.
Yeah. So
Now,
it depends
here's
on the
one thing you
institution.
may
Yeah.
not know, and this is
Hmm.
I have not independently verified this, but I've heard it from 3 different sources. So our biggest hospital system in the state, what they, let's say that an internist decides, this isn't for me, and they leave. Do you know what it costs them to replace that internist in recruiting fees? And just think about the fact that they got to bring the person and their spouse, put them up for a few days in a hotel, fly them out here, wine and dine them.
Yeah.
Some small percentage is going to say yes after all that in Idaho, because
Yeah.
it's not the biggest place in the world. And so they end up spending around $500,000 per um, candidate, or not per candidate, but per site to fill a slot. So
Oh
if
wow.
they can do this and get 3 years of watching them and really evaluating them, which nobody's on the hook for permanent employment yet,
Yeah.
and they have a super high success rate, because if these guys spent 3 years in this system and that's the system they know, they're most likely going to stay in that system. So
Yeah.
this is kind of like a little cheaper than recruiting, even for 3 years of salary. And it's a better match that we know they will succeed in our system, and they know they would like our system. So that's
Mhm.
how we post it. And what we do is we ask them to roughly match an intern salary and then resident salaries for that first year. So
Mhm.
intern salaries in our University of Washington residents are now unionized, and
Okay.
so those salaries are pretty reasonable. And so I don't tell them what I think they're going to get, because that's up to the sponsoring institution to
Yeah.
look at their own finances and stuff. But for many of these people, when you point out to them that what do you actually spend to fill a position, I
Mhm.
mean, because you go through 7 or 8 or 9 candidates before one really says yes, and then how long do they stay?
Yeah.
It opens their eyes to the fact that this is a much safer way of doing it.
Yeah. They're also paying a lot of staffing agencies.
Yep.
So many costs out there that's going out the door, especially in remote areas. So definitely, I think this is a great opportunity. Dr. Smith, where do you think this is headed? Like, just looking at the entire nation, and like the population is getting older. We have these alternative pathways. Residency is not no, there are not a lot of more spots being created. Funding is at risk right now in the federal government. uh, where do you think this is headed? Like, do you think ultimately these, boards have to get on board to this and say like, hey, like this is what makes sense?
Well, this is a balance between income and altruism for those boards, right?
Yeah, yeah,
Like if you have to take our boards, that costs a lot of money of study materials and going to the boards and whatnot.
yeah.
So they get a pretty good income out of that. I was a ACGME, I'm sorry, a USMLE question writer for 8 years too.
Mhm.
So I know the huge expense they go to get a valid test, but also the huge income that they make from all of this stuff,
Yeah,
right?
yeah,
And so it's hard for them to give that up. But I think the nation is getting pretty desperate.
mhm,
Almost every state has some degree of physician shortage, certainly in
yeah,
primary care, certainly in rural areas.
mhm,
And I think the DO schools have moved forward to try and fill that niche because they say MDs aren't doing it.
yeah,
You get something like WWAMI,
mhm,
our Washington, Alaska, Montana, Idaho, and Wyoming. That was actually I was part of WWAMI from the very beginning,
mhm,
and when we added Wyoming, there was like a 1 year controversy about what are we going to call ourselves? Are we W squared AMI or are we WWAMI? And how do we pronounce it? And we've got all this recognition out there. So
yeah,
for your viewers that don't know about this, it was created about 50 years ago, and it was 5 states in this country don't have their own medical schools, and the only one that isn't touching University of Washington and Washington was Maine, and they
yeah,
have partnered with Vermont and stuff. And WWAMI was created to say, we're going to go to all these states where they have vet schools and stuff, a lot of the expertise for the first year of medical school.
mhm,
Let them do first year in their home state, second year back in Seattle, and then go all over this 5 state area for their clinical training.
yeah,
And this is part of why Washington has been incredibly successful, both in US News and World Report rating for primary care, which has been #1 for like nearly 30 years,
mhm,
but also for state school funding from NIH. Because when
mhm,
you get towards the end of your second year, you were like encouraged strongly and you had an advisor to help you. Think about, do I want primary care and clinical practice, or do I want research and subspecialty practice?
yeah,
And right away, you'd get a mentor. If you wanted clinical practice, you could try out sites for rotations in Alaska, Montana, Idaho, Wyoming. I was born in Idaho, but I was raised in Washington, and I was a
mhm,
Washington whammy. But
mhm,
I came to Idaho for several rotations, including internal medicine at the site where I came back as a resident and where I came back as residency director.
wow,
I just loved it. And
yeah,
so it was really good at kind of placing you in the places you wanted. And I had tried out Wyoming and Alaska and all of that. Well, the ones that decided on the other pathway would be matched with, let's say they want to do cardiology and maybe want to do research. Great. Then they have some sort of world famous researcher in cardiology that they get as a mentor that helps them to understand how you write grants and get grants and also do cardiology in clinic, et cetera, et cetera. So they've
mhm,
been really successful with that pathway, and that was a lot of influence for me as I was being up through
yeah.
the system.
Man, that's amazing. Dr. Smith, if somebody's interested in this program, let's say they're a doctor, international medical graduate in Idaho, and they say like, hey, this is a great fit for me, or maybe they're somewhere in the country and they want to move to Idaho. how can they get in touch with you or like the program?
So, under this new grant that we got, there's a young lady who is managing the grant. Her name is Victoria Siedakova. She's a Ukrainian. And her email, I probably don't have off the top of my head, but
Yeah, we can post it on the show notes.
okay. So she right now she has been accepting applicants for these sites that we're starting up with, and we've had people from all over the country. But just remember that the only people we can actually put into this system have already passed USMLE 1 and 2, have already done a residency or something that looks like a residency in their home country, and have as practiced for at least 3 years in their home country.
Yeah.
So there's a lot of people that apply, but they don't meet the criteria.
Yep. And Dr. Smith, let's say somebody like, 'cause I know in some countries they do 1 year of internship and then they work as a general practitioner for a couple of years, or maybe their
They should
lifetime.
still
Yeah.
apply.
Mm.
We will take a look at their application pretty carefully and see. Basically, the determination we're trying to make is, can we get this through the State Board of Medicine into the program
Mhm.
with either a rule promulgation that we need to add, or they'll just give them an exemption for what they've done if it's good enough. So if that person did a year of internship and a couple years of GP, they would have to have very strong US experience to pull them up enough for the board to consider them.
Yep. Awesome. Sounds good. Last question, Dr. Smith. If there's like an advocate out there trying to do the same thing that you're doing in Idaho in a state that doesn't have this type of program, what advice would you give to them?
Well, so two pieces of advice. One is link up with somebody in your legislature that's friendly to this idea and get mentoring and help. Because that first year, literally, the senator took me around to these offices, knocked on the door, and said, "This guy needs to talk to you about a quick visit, 15 minutes on your schedule." So you need someone like that to get your foot in the door. That's number one. Number two is not only people that want to be advocates for these programs, but I think any citizen that's interested in getting more physicians in your state needs to help lobby at the federal level to get these Medicare changes for more support, because that's how we've decided as a country to fund residency training. I think this is a necessary end around from doing residency. I still think most of us are better served by going through a U.S. residency, getting enculturated into how things are done here differently, and used to an EMR if they've never been using one, et cetera, et cetera. Those things just, 3 years in a residency really helps to come out polished and ready to go, even if you've done something pretty similar in your home country. Now, the more similar it is, there's certain countries that the U.S. will just say, the United Kingdom, Canada, Australia, et cetera, that they'll just say that's close enough. You can go through our process.
Yeah. Yeah.
And I think that we need to change that entry level and the huge bottleneck of residency positions, either directly funding more from your state, which we've done some of and been somewhat successful, but also getting the Medicare pass-through positions increased, because the population of the country and pretty much each state has gone up a lot since 1997 when those caps were set.
Yep. That's true. I agree. Dr. Smith, Scott Smith, everybody, former program director at the University of Washington Internal Medicine Program, Boise, and current medical advisor at Global Talent Medical Docs, Idaho. Dr. Smith, thank you so much for joining the show. I'm definitely going to call you again. I'm going to bug you a quick few times to join us and keep us updated on what's going on in Idaho.
I think that'll be important. I think we're really in the top two or three of getting through this thing. So
Yep.
I think we've got some good lessons learned that are a bit hard, and I think we'd probably be helpful down the road some too. I will send you as soon as we get off here. I'll send you Victoria's email so you can get a hold of her. Your people can get a hold of her.
Yep. And for everybody listening, we will post that in the show notes, or you can have it on the social media post. We'll have it on there as well. So till then, we will see you guys very soon.
Thank you so much, Mohammed.